So this is my spirit animal. These are two of my kids a couple years ago now, but my spirit animal is what's called a tardigrade. And I don't know how many of you know what a tardigrade is, but it's a little invertebrate that is resilient as hell. You can send them into space, you can heat them up to a high temperature, you can freeze them, you can do anything, and you cannot kill them. And that's what we need to learn in our lives, is how do we become resilient? Because resilience is going to be the key for not degrading as we age, right? It's going to be, how do we make ourselves resilient? And the tardigrade actually uses some techniques that we actually have that we can use too. So I know most of you, and I know most of you are here because you already have spine problems, knee problems. In fact, many of you, multiple of those things. And there's no surprise, because people who have knee problems often have back problems and shoulder problems. Most of these diseases are linked. So it's not like, oh, I just hurt my knee and I wore out my knee. Most of these diseases are linked. If you have one bad joint, you likely have another bad joint or will develop another bad joint. So this is a cell phone. This is a Motorola cell phone from the mid-'80s. And, and some of you remember this phone. And we thought that was really cool, right? We actually had a phone that we could actually carry. And now this is our cell phones now. There are mini computers we can carry in our back pockets. So since 30 years, 40 years has made a humongous difference in this industry. How about the TV? I mean, this is a TV from the 80s. You remember them, right? They were huge, they were heavy. When you tried to get rid of them, it was impossible to carry them out. And now this is a TV now, which is, significantly better. And that's, again, over a 30-year process. So this is the total joint. This is a slide actually so this is a picture from about 1980s. This is a picture of the total joint. So it's the same time as that Motorola cell phone. So this is our total joint now. It looks pretty much identical, with the exception of now we think it's cool because we can use a robot to assist in putting the joint in. And that has helped. That has made the joint placement better, but it hasn't really changed the joint replacement. In fact, we're super proud of the fact that, honestly, we're still using the same technology that we used in the early 1960s. I mean, this was like, wow, look how cool we are. We're using the same technology we used in the 60s. Any of you who are in the tech field, I know a lot of you are, would be like, oh my God, I can't believe we're doing the same technology that we used in the 60s, but we are. So why is that? I mean, there's a lot of fear in change for all of us, right? It's really hard to change. Even if we know it's for the better, it's really hard to change. So there's a lot of fear that keeps us from moving on. In orthopedics, it's also a lot of stubbornness. It's like, you know what, I've got my hammer and this works really well, and I don't want you to tell me there's any other way of doing this, right? So there's also a lot of that in the medical field in general. We spent a lot of years and a lot of time learning the way we do things. And for somebody to come tell me there's a better way, I don't want to hear it. I literally spent, how many years I did 4 years of medical school and 5 years of residency and 2 fellowships. And now for somebody to tell me that everything I learned is not right, or largely not right, is hard. And it's a lot of an adaptation to say, God, I spent 30 years of my life learning this, and now somebody wants me to learn something differently. But you have to, and I will tell you that the stuff I learned a year ago is outdated in the field that we're doing with the cellular medicine field. So, this approach works well, right? What we're doing works really well. And I just had this discussion with my son's girlfriend tore her ACL skiing a few months ago. And they came out for a romantic ski weekend. And of course, she, 2 minutes into the run, tears her ACL. And I said, hey, there's some better ways of fixing ACLs. There's this new procedure that a couple docs are doing. And her parents were both physicians, talked to their orthopedic surgeon who said, there's no reason to do these new procedures because this one works well. But it doesn't. I mean, if you look at the numbers, 80% of patients who tear their ACL and the meniscus, and they usually go hand in hand together, 80% within 10 years. Within 10 years. I mean, this is an injury lots of times in 18-year-olds have arthritis. If you just tear the ACL alone without the cartilage, you still have over half of those are going to develop arthritis. I'm a victim of that. I have horrible knee arthritis, end-stage knee arthritis. Tore my first ACL when I was young. So we have to rethink this. And they're doing this. Other countries are starting to look at this. Not so much here, but in the UK, they're really looking at, should we be doing different approaches to this? We should be looking at osteoarthritis differently. And that's what I want you to understand by the end of this talk. What is osteoarthritis, basically? There's all these different types of arthritis. And we've always kind of classified arthritis as inflammatory, like rheumatoid arthritis, or osteoarthritis, which is wear and tear. And by the end of this, you're going to understand that they're not different diseases. They're really similar diseases. But basically what happens is something damages the cartilage, or You know, you have a little injury to the cartilage, and it begins to wear out, and then or you tear the meniscus, the cartilage begins to wear out, and then you start getting these bone spurs, and you get up to this knee with, these, like my thumbs, this big arthritic joints, and the cartilage is worn out, and it's painful because there's a lot of ingrowth, little weird nerve endings that occur. And we've always thought it's just like wearing out your tires. You hear that all the time, right? That, well, you just put too many years on your knees, which is bull. I mean, did you put too many years on your brain and your heart? I mean, no. I mean, this is not a disease of just wearing out. I have football players who aren't worn out. And then I have little ladies who did nothing for their life, were housewives, and they're worn out. It doesn't make sense. We don't think about dementia as you used your brain too much and put too many miles on your brain, right? That would be stupid. If someone said, oh, I know, that's because you were an engineer, so you're super smart, so you just wore your brain out. We'd all laugh. But your doctor tells you that about your joint all the time, right? You just used your joint too much. This is a disease that affects, it's the third leading cause of pain as we get older and bad health. So, hypertension, high cholesterol, first two. Arthritis is the third leading cause of your health declining. In young people, so this is working age people, right? Musculoskeletal injuries and back injuries are the leading cause of disability. So loss of work life, right? The loss of our really productive years is occurring at an epidemic. And it's increasing. I mean, when you look at the projected people who have arthritis, and yet very little of our time and energy and money in research on medical conditions is being spent on arthritis. In fact, if you look at disabled veterans, 1 in 3 veterans have severe arthritis, so it's pretty bad. And yet no money from the Department of Defense is being put to that. They're looking at other things, post-traumatic stress disorder, but not to arthritis, and yet 1 in 3 are debilitated by that. First thing they do is, here's what I want you to do. I just want you to start using your joint less, right? So they say, so stop jumping, stop skiing, stop all the things you love. Just take it a little more easy, which I will argue is maybe one of the worst things you can do to somebody for a couple of reasons. Number one, mentally they go downhill. They're depressed, life sucks, so that's not good. But also because you'll learn that motion is really necessary. Muscle is really necessary for joints. If you do not have muscle, your joints will not be healthy because muscles produce myokines, which are little proteins that tell your joints to regenerate. So if you lose muscle because now somebody told you to stop exercising, your joints start to degrade. And then you get more pain and you work out less. So you have to keep people exercising. There's always ways to do that. There's lots of modifications you can do. And then when the do-nothing approach, when you're like, well, that do-nothing approach didn't work, doc, they go, okay, we'll try a little physical therapy and chiropractic, which can be great, and it can definitely help, and it can keep you going. It's not going to reverse the arthritis. It's not going to stop the inflammation. So then they say, okay, let's start you some anti-inflammatory medications, which have some huge benefits. And then that doesn't work, so let's inject some corticosteroids. And then lastly, let's just go scope the knee and then replace it. So let's talk about, do those things work? February 2019 article, big article, looked at steroid injections and in knees. They did it in knees, they didn't do it universally, but we can assume that other joints follow the same suit. Those who used intra-articular corticosteroids had substantially faster disease progression. Now, do I think you should never use steroids? No. I have patients who come to me in acute pain, and I'm going to put a little steroid in their joint sometimes because they literally can't move. But will I do that over and over and over again? No, you can't. And I've learned that through my years because I used to do that. And now I've learned maybe the damage I've done from doing that to people. And I'll show you why here as we get through this talk. And then there's hyaluronic acid injections, things like Synvisc, Euflexa. Basically, it's a synthetic joint fluid that we put into the joint to pad and cushion the joint. And those probably work a little bit better. 66% of people had 66% of relief. 30% of those, however, went on to having surgical replacement within 7 months of treatment. So it was a temporizing measure, to get people through. And, I think it's better than steroids, but it's not going to get you cured. So then, next step is they're going to actually go in there and say, well, let's go in there and let's clean up that joint. Let's just scope it, and we'll clean it up, whatever that means, and that'll help. And yes, that'll help for a few months, maybe a year, and then you'll actually be significantly worse. In fact, in other countries, they actually have stopped allowing joint replacements. Joint arthroscopy in people who have any kind of degenerative findings, even if they don't have imaging evidence of osteoarthritis, mechanical symptoms, or sudden onset. So if they're over the age of 40, they will not do arthroscopy on the joint because it made things worse, not better. And they felt this was so compelling of evidence that they were making people worse by scoping joints that they said there's no amount of evidence beyond this, what we've done in this study, that's going to change our mind. And so in most countries now, it's not allowed to do joint scopes on somebody over the age of 40, only on young people, because the substantially worsening of the procedure was so dramatic, or of the condition was so dramatic. So after they scoped a knee, they saw a rapid decline in function. So then we look at joint replacements. And joint replacements, I'm not going to argue. I know some of you have had joint replacements here, and they can be life-changing. Once you have severe arthritis and you're debilitated, this can be a life-changing surgery. Our goal is to prevent you from getting there, but we also have to look at who these are being done on, because they're being done on younger and younger people. And when you look at, unless you're in severe pain and severe dysfunction, it doesn't buy you a whole lot. And in fact, those people a lot of times go on to have complications. So you have to selectively pick who you're going to do that surgery on. This is another study out of British Medical Journal where they looked at actually every orthopedic procedure. And what they found is that there was no evidence for most orthopedic procedures that showed clinical efficacy beyond just some anecdotal evidence. And that the only thing they could come up with that was really actually truly beneficial was carpal tunnel release out of all of these surgeries, which had some temporary benefit but not long-term benefit, and no more benefit than physical therapy. And I'm going to advocate that a lot more can be done than physical therapy. And they're not without complications. I mean, lumbar surgeries, 20% complication rate. ACL reconstructions, 40% complication rate. You know, these are not surgeries that we should take lightly. Again, I recommend surgery on patients. It's not a never do surgery. It is select the right patient and do it for the right reason, only when you've actually gotten that patient's health the right place. So we have to rethink what we're doing, because we have an epidemic that we're doing absolutely nothing to change. We're spending a lot of time trying to change COVID, but we're not spending any time on changing the leading cause. I mean, and my dad, who died in his 90s, was debilitated by arthritis, and he was a super fit, active, healthy guy, and he got miserable because he couldn't walk anymore, right? I mean, even if you're mentally with it and everything's great, if you can't walk, you're miserable. So we have to understand this is not a wear and tear. It's not just wearing out your tires. You did not put too many years on your knees. This is an inflammatory disorder, and it can start very young for a lot of reasons. Genetics play a huge role there. Environmental influences play a huge role. We'll talk about that. So all of these diseases, whether it be dementias, cardiovascular disease, cancers, metabolic disease, arthritis you'll see is a link to all of those. They all come down to an accelerated aging process, which oftentimes begins at a very young age. It's why people who have articular damage, who have osteoarthritis, about half of them, if you look deeply, have cardiovascular disease as well. Because we know those same inflammatory processes that are going on in the joint are going on in other tissues and destroying other tissues. It's one of the reasons you can't just say, oh, I have an arthritic knee. You have to look at the inflammatory process because it is destroying the rest of you. So this is a process called inflammation. It's a disruption in the immune system that now creates damage to a whole bunch of different things, and we'll go through this. So basically, if you get sick, if you get COVID, or you tear a meniscus in your knee, or you herniate your back, disc in your back, those are all the same process. Your immune system, whether it's COVID or a tear to the disc in the back, your immune system senses that this has gone, something's bad. And your immune system sends in a reaction. It's an army. They're trying to heal you. Get rid of the COVID, or try to heal your meniscus, or try and heal your disc. So they upregulate what we call inflammatory or pro-inflammatory proteins, things called cytokines. Cytokines are messengers sent by your immune cells that tell more cells to come in and help fight the battle, right? And that's necessary. If I get COVID, I want that pro-inflammatory reaction. If I tear my meniscus, I want that pro-inflammatory reaction. But I don't want it to stick around. Once that, that redness and swelling and all that stuff, right? That's all good. It's getting blood flow to the area. That shouldn't last long. It should last 3-5 days, right? And then these things go down, and we see an increase in the anti-inflammatory cytokines. Those are the guys who are like, okay, done with the inflammation, let's heal. Let's replace the meniscus now. If it's COVID, we start getting the immune system back. When people die of COVID, what is it? You've heard this. It's called a cytokine storm. Their body overreacted to the COVID and destroyed everything. When you tear the meniscus in your knee, if your body overreacts, or you injure your back, if your body overreacts, you start the exact same process. It's a cytokine storm in the joint. So what happens when I put steroids in? Well, steroids are great. They reduce all of this inflammatory stuff, but they also reduce all of this inflammatory stuff, which is why the steroids have a bad effect on you being able to heal. And now what happens is whatever injury occurred, be it a little injury to my disc or my knee, then that is going to progress because I've blocked the ability for you to pull in the healing factors. So if you do steroids, you've got to follow that and make sure you pull in a bunch of things now to try and improve these briefly after you do it. That's why that stat I showed you exists, that once you actually put steroids in, I can't heal. So here's the process. So why does this occur? Why does our immune system go awry? Lots of reasons. Age in and of itself. And the reason age, if I'm a perfectly healthy 60-year-old, that'd be great. But most of us aren't. Our immune systems have struggled with a lot of viral exposures. There's a lot of environmental exposures. The same thing happens in young people because now young people have all this stuff going on. How many young people do you know who have, mono and how many who eat sugar all day long? And I will tell you that hormone deficiencies, women on birth control pills, all those things. We're seeing a rash of young males with hormone deficiencies. All of that has the same intrinsic factors as aging does, right? And then there's all these extrinsic factors. Again, we're exposed to all these environmental stresses. So now I get a little injury, a little mechanical stress, and you put all of that together. Once these guys go up and they stay up, they start destroying these cartilage cells. Cartilage cells are called chondrocytes. So once those cartilage cells are damaged, they become what we call senescent cells. This occurs in every organ system. There's damage, and once those damaged cells occur, so you have this little injury, these damaged senescent cells actually start producing more inflammatory cytokines. So once you have a rash of damaged chondrocytes, they produce more inflammatory cytokines. More inflammatory cytokines causes more immune reaction, and that process tailspins. They're what we call zombie cells. And these are, we think, a big cause of aging everywhere in your body. These damaged cells create what we call senescent proteins that damage more cells, that damage more cells. It's why you can get a little tiny injury to the knee or the back, and it seems to rapidly progress. A lot of you experience that, right? You're like, God, I just barely tweaked my knee, and it just went downhill after that. This is the process that occurs. So if I go and I scope this knee, and I clean it up, and I'll just sort of shave this cartilage edge, and all will be well. What did I do? I created more inflammatory cytokines, and I started that cascade downward, right? And then I put steroids in, and I block these for about 2 weeks, and I block all the healing things, and now I've really created a detrimental event. And again, age is a factor because our immune systems are dysfunctional. I will argue that I have a host of 18-year-olds with dysfunctional immune systems in my practice. Same thing happens with the disc. You injure your disc a little bit, designed to heal, but once you get this inflammatory reaction, the disc turns just like the joint. You start damaging the collagen, actually change to a completely different type of collagen on the outside of the disc. If I put steroids in this, I actually worsen this collagen dysfunction. The collagen becomes floppier. The other thing we know, and this is complicated, but this is the other pathway, is that once there's immune dysregulation, our body tries to react. So our mitochondria, remember mitochondria from high school? They're the powerhouse of the cell, right? They make energy, they make ATP. So if I'm injured and my body's trying to clean up, I'm rapidly using my ATP up. So my mitochondria are trying to react. So they start going into overdrive. The mitochondria start trying to produce ATP. We do that through a process called oxidative phosphorylation. They start pumping out ATP. But when the mitochondria start pumping out ATP, they also start accumulating a whole bunch of what we call reactive oxygen species. It's a natural process in oxidative phosphorylation to have reactive oxygen species. But if we don't have too many, we can deal with them. If we have too many, we can't deal with them. So once you get accumulation of these reactive oxygen species, they actually start damaging the DNA. So your mitochondria have their own DNA, so they start actually damaging the DNA of the mitochondria. Once you have damaged mitochondria are really, really bad. And they actually start going haywire and producing so many damaged proteins that you actually start getting sicker and sicker all over your body. It's why you can have arthritic knee and I'm so fatigued. Why don't I feel as like I just don't even feel like I have energy anymore. Same thing happens after COVID. You damage the mitochondria. And then you have these people who have long haul, or if any of you had COVID, it's just so hard to get your energy back. It's because of all these mitochondria that have gone haywire. So what our body's designed to do is when there's all these damaged cells and damaged mitochondria is to get rid of them. It's called autophagy, clean up, take out the trash. But when we overwhelm that system, because there's too much damage, then the autophagy process doesn't work. As we age, autophagy doesn't work as well. So now we've reduced autophagy. So we're not getting rid of the damaged cells, right? The damaged mitochondria. They haven't killed themselves off. That's that zombie cell process. So now they are creating more oxidative stress. The mitochondria are pumping out more reactive oxygen species. The damaged chondrocytes in your joint or the disc are creating more of those pro-inflammatory cytokines. What does that do? Once I have a whole bunch of inflammatory cytokines, one thing my body does is start storing fat. Because when my body's in a stressed state, what's its natural reaction? Oh my God, the world's ending, I'm going to be starving, I better store fat. So now your body starts making fat cells. Well, fat cells love inflammatory cytokines. They're the only tissue in our body that loves inflammatory cytokines. They feed off of them. So they start growing. When docs say, oh my God, you're just too fat, that's why you wore out your knee. Maybe you wore out your knee and you got too fat because these adipocytes start thriving on these inflammatory proteins. And they start producing something called adipokines. Remember I told you about myokines that come from muscle? Myokines are great. Adipokines, not so much. Adipokines produce even more inflammatory proteins. So now you get systemic inflammation. Now your heart starts going, your brain starts going, right? You get fatter and fatter. So if I just go scope your knee or replace your knee, have I fixed any of this? No. It's why 70% of people who have a knee replacement will need the next knee replaced. 50% of those will need their hip replaced. It's a downhill cascade. You've got to start treating it early. So if I go in and I trim out bad parts, again, you'd think I was crazy as a doctor if you came to me with dementia. You brought your elderly mother in with dementia, and I said, I'm pretty sure if we just cut out that bad damaged part of the brain, she'll be good. You'd look at that doctor like, oh my God, they're crazy. And yet every one of you has heard your doctor say, let's just go in there and let's clean out that bad part of the cartilage. It's stupid. It makes zero sense. And it's the #1 surgery that we do here in the US. So what do we need to focus on instead of that process? Here's what we need to do. We have to lower those pro-inflammatory cytokines, raise the anti-inflammatory cytokines. Remember that thing, that balance I showed you. We have to stop these enzymes, something called metallomatrix protein and ADAM3 enzymes. These enzymes, these degradative enzymes, which are causing so these enzymes are coming in to clean up the mess. But I always tell people it's a little bit like if I have a spot on my wall, if I keep cleaning that spot, there's no wall left. So when those degradative enzymes are upregulated, they're wearing out the cartilage even faster. So you've got to block those. Then we've got to repair the mitochondria. We showed you how they're playing a big role in this. We have to improve autophagy to kill off the bad stuff, and then we can initiate repair. Lots of times in regenerative orthopedics, and I see this all the time because there's a ton of clinics doing regenerative orthopedics. I've been guilty of this too because I didn't know everything 5 years ago that I don't know now. But if I just throw stem cells into you and your body is completely in this inflamed state, what's going to happen? Not much, right? You just kill off the good cells. This is, we call our practice what we call next-gen regen, so next-generation regenerative medicine. Basically, we're looking at regenerative medicine by fixing all those processes and then seeing what we can do to kind of repair. And we have a lot of options there. And so when I got into this Facebook argument, and my old partner Bill said, well, I was just at AAOS, which is the Orthopedic Society meeting, and he said there was lots of talks about biologics. Biologics reduce those inflammatory cytokines, so they have some benefit. It's not the only approach, right? You have to look multi-system. So I'm going to give you some, and again, this is the part I'm going to kind of rush through, so we have some time for questions, but But I want you to know there is some really cool stuff available and on the horizon that we can do to address all of these things. One is what we call repurposed drugs, drugs that are already available here and FDA approved, but not for the purpose they're being used for, repurposing. This is a drug called Pentosan Polysulfate that is widely used in Australia. In fact, they put all of their Australian football players on it because they all get these knee injuries and they don't want them to progress into arthritis. So they put all of them on it. And we started using this. We could get a pharmacy to make it for us, even though it wasn't available here in the US. It actually, interestingly, about 2 months ago, it got FDA trial approval here. So starting some trials on it here. It's been available since 2019. It's what we call disease-modifying agent of osteoarthritis, meaning it's actually potentially what they think, at least in Australia, a cure for osteoarthritis. I don't think it's the whole picture, but I think it plays a big role. It's an approved drug. It's been widely used in horses and dogs. Racehorses get all the cool stuff first. So it's been around in other purposes. It's got multiple studies to support its efficacy and its low risks. This is just looking at improvement in the, so when you have an arthritic joint, some of you have seen this, or arthritic spine, the bone actually gets this kind of swollen appearance. It looks white on an MRI scan. That's edema in the bone. It's swelling in the bone. It's very painful. You can see that it reduced the volume of swelling in total, this is in a knee joint, total volume of that swollen area in the bone dramatically. And the medial compartment actually reversed it. This is kind of looking at, so it's a little injection you have to learn to give yourself, a subcutaneous injection. I do it up here in my hip. So basically, this is after using the injection for 6 weeks. The VAS score is a pain score. You can see over 50% reduction in pain and 50% improvement in function. It maintained, they stopped doing the injection after 7 weeks, and you can see at 52-week follow-up, they still had significant improvement because you actually made some permanent change to the cartilage and significant improvement in function. So it was actually more of a cure than just a treatment. Now, I will say that I stay on this drug all the time. If I stop it for a while, my inflammatory stuff seems to escalate. So I stay on it all the time. But it's been dramatic. And again, I have end-stage knee disease. It's been dramatic in keeping my knees from hurting and hopefully improving them. And why? Well, go back to that picture. Here's what happens. Increased tumor necrosis factor alpha, increased metallomatrix protein. What does this do? It works on interleukin-1 beta, interleukin-1 beta right there. It works on TNF-alpha right there. Same inflammatory cytokines that are associated with heart failure. Coincidental. So that's why I don't want you guys to I don't care if you get your knee replaced, but treat the thing that caused it because it's creating other problems in you. I do care if you get your knee replaced. These are those degradative enzymes. We don't have anything in our medical armamentarium that treats these degradative enzymes, except this drug. Again, hopefully I think it'll be available probably in the next 5 years here in the US. Right now we know how to get it, but it's, and in fact, it was funny because one of my patients brought in his business journal, which is where probably the best place to learn about these drugs that everybody gets excited about. And it was like, this is the, buy stock of this company. This is going to be the blockbuster drug of the century. We've been using it for about 3 years, since 2019, so it's getting, with dramatic improvement. The longer you're on it, the better you seem to do. So really, these are all of the different places Pentosan's working. So we call it Pentosan Polysulfate, or PPS. It's working on all of these different pieces that are contributing to pain, but also contributing to the further degradation of the joint or the disc. Think of them simultaneously, the same things happening, disc and joint. So if I have a kid who injures their back or tears their ACL, I'm going to put them on this drug right then, because that's when this process is starting. So I can normalize that inflammation. So I don't let that kid go on and have a 80% chance of developing arthritis, right? So we got to focus on this. You've got to get these kids, or if you're 20 and you hurt yourself, so that's one of the things I want you to think about. And I know we're all past that age, but you can still pass that news on. But it still works. I mean, I started this drug in my 60s, so it still works to help people now and to stop the progression and to dramatically help pain. It's, how about like other drugs? Metformin's a diabetes drug, but we've learned that it has other huge health benefits. cardiovascular disease, really it's an anti-aging drug. It reduces DNA damage, reduces inflammation. It helps liver, helps obesity. So if a drug works that dramatically, we thought, would it work in arthritis? We did a little research, and yes, indeed it does. And in fact, in mice, at least, dramatically relieve their pain and reverse the arthritis in their joint, or at least if it was severe, stop the progression. This is a $6 a month drug, that you get from the general pharmacy. And it has huge health benefits. How about simple supplements you can do? So, number one, you've got to optimize things like vitamin D. Every one of you in the room needs 10,000 IUs of vitamin D with K2. Vitamin C can be super helpful. We'll sometimes run IV vitamin C, especially if there's collagen disorders, if you have tears in fascia, things like that. Vitamin C is super helpful. But a couple of these others you might not have heard about. Epigallocatechins, trehalose, and spermidine. And I'm going to argue that these, every time I'm talking, go back to those pathways, right? You've got to stop the inflammatory cytokines, you have to improve autophagy, and you have to repair mitochondria. So can we do that? Well, epigallocatechins are what are found in green tea. EGCG is easier to say than epigallocatechin. So they're found in green tea, but look at what they're doing. So this is a study done in 2020 showing significant benefits simply from epigallocatechins on arthritis. Because here's what happens in arthritis, right? We talked about this, particularly this guy, interleukin-1 beta, but TNF-alpha, increased inflammation, increased oxidative stress, everything you just learned. Well, what does epigallocatechins do? It basically reduced every one of these and reduced some of the oxidative stress from the mitochondria, and we stopped the cartilage degradation, stopped the pain, and improved functional scores. This is a really good supplement. You have to high dose it a little bit, sometimes going up to 1,000 twice a day, but at least 500 twice a day. That is hugely anti-cancer because all these inflammatory cytokines also play a role in cancer. So it's hugely anti-cancer. It has so many health benefits. What else do we have to do, right? We talked about repair the mitochondria and improve autophagy. Those are the other pathways. It's why when I got in that argument, that Facebook argument, I said, you're not going to address this from one pathway. It has to be multiple pathways. So you have to think a little, again, this is a cellular problem, just like every disease. And until docs start relearning biochemistry, not going to treat this. So mitophagy and degenerative joint disease. Mitophagy basically means autophagy, remember self-death, inside the mitochondria. Get rid of the damaged mitochondria, right? So no one's ever looked at that. This is a study that came out at the end of 2020, and no one had ever looked at, maybe it's the damage that's creating the damage. It's these damaged cells. And what they found is that by simply focusing on improving mitophagy, killing the damaged mitochondria, they had dramatic improvement in arthritis. No one's really followed up on this much, but it was a pretty interesting study. So how do we do that? Well, there's actually a very interesting supplement called trehalose, and it's actually sugar. We use it to sweeten everything. One of my patients always makes me cookies with it. It has no glycemic impact, meaning it doesn't raise your glucose. It has really good neuroregenerative benefits. In fact, it's an orphan drug right now for treating ALS. It's called SLS005. It's a simple sugar. So I use it to sweeten everything. I use it in my coffee. I use it in my protein shakes. I use it for everything. So super, it supports cognitive function. It helps reduce oxidative stress. And it protects the good mitochondria and promotes autophagy in the bad mitochondria. This is a sugar. Again, a sugar that has no glycemic impact, is a healthy sugar for your brain, for your joints, easy to do. So it again, stops senescent cells, so it delays aging, improves autophagy, helps, reduces oxidative stress, reduces inflammation. When you think back to a very interesting fact about my tardigrade, they make tons of trehalose. Is there a connection? This is so DMM is an agent you can inject to just rapidly destroy cartilage. So this is a mouse knee. You can see the cartilage space here. That's what it should look like. That's like the meniscus in your knee, right? When they put DMM in, you can see it completely collapsed. This is DMM and 2% trehalose. You can see the improvement in the joint space here, not so much there. When they went to 5% trehalose, joint went completely back to normal. Did not see any of the degeneration. So we know, at least in an animal model, it works. It's safe. It's simple. It has zero side effects. Zero. And then a more interesting supplement called spermidine. Spermidine got its name by Antoine van Leeuwenhoek, who discovered the microscope. And if you're a guy and you discover a microscope, the first thing you do is look at your semen. If it was a girl, we never would have found this because we would have looked at something really important, but not a guy. So they looked at semen. He saw this crystallized substance, and it turned out to be a polyamine called spermidine. Spermidine is naturally made in our body, high quantities in breast milk and in semen. And you also get it from some foods. But it's really associated with longevity and health. Brain function, huge. Higher levels of polyamine, less brain dysfunction as you age. Really boosts what we call autophagy or mitophagy, gets rid of those damaged cells. This is a supplement that I think everybody should be on, at least at a low dose. You probably need higher dose when you have to correct like an underlying arthritis or something. But, this is looking at what's called synovial pathology score, so damage to the lining of the joint. So after they damage the lining of the joint, they put them on, this is steroid, this is low-dose spermidine, high-dose spermidine, and this is the mouse that they did nothing to the joint. And you can see that high-dose spermidine worked better than steroids for helping the inflammatory process, so getting rid of these bad cytokines, remember those pro-inflammatory cytokines, and unlike dexamethasone, it increased the good cytokines. So should we be using this instead of steroids? Probably. Works again just based on stopping this process of healthy cartilage going to osteoarthritic cartilage. It's hugely beneficial for longevity in general. I really, honestly, guys, this is a supplement that really I've been trying to get for years, and I finally got it from Austria. And now they've kind of made their way to the U.S., and it's the #1 selling supplement in other countries for obvious reasons. And then I'm going to briefly run through the next few things. I want you guys to know these are available. Peptide therapies are huge for helping this process as well, particularly in the repair process. The peptides are really just small chains of amino acids. You make thousands of them. And basically, they're really, really safe because they have really specific actions. Whereas hormones and steroids have very broad reaching actions, peptides have very small mechanisms. And so they're super safe and super beneficial. You can use them, there's nothing really you can't do with peptides, honestly. I mean, you can use them to control insulin, you can use them to address cardiovascular disease, athletic performance, you can even there's one called melanotan that makes you tan. I mean, you can do tons with these. A simple one that you could all add to your regimen is a collagen peptide, because that's a powdered oral peptide. And people always go, oh, you can't eat collagen and make collagen. You can. In fact, this is a knee pain for walking. So this is just the difference in joint pain on a placebo versus with the collagen, what we call a collagen hydrolysate. And you can see the difference also in pain just standing still. So, dramatic difference from a simple little powder that I just throw into my water bottle. This is probably the Fortigel is the collagen peptide that has the most research behind it. But this is a study that they did in 2007. So it's an old study using Fortigel and looking at the cartilage and then its repair. So cartilage should be nice and smooth like this, not all shaggy like this. And you can see the repair in the cartilage just by using collagen hydrolysate with Fortigel in it. And then there's this peptide that really honestly is almost too good to be true. It reduces inflammation, it repairs damage, it promotes healing. We use this in our athletes all the time who have injuries. If you injure a tendon or a cartilage, and you start something like BPC, it has dramatic. But even after you have arthritis, it dramatically helps with pain and healing. It's naturally produced in our body by our gut. We make less as we age. It's one of the reasons little kids heal really fast, and it has really zero downsides. You can dose it up to massive doses. Its biggest downside is expense. Most peptides we have to get specially made from different pharmacies throughout the US, so they're not inexpensive. But you oftentimes can do them just off and on when you get like, oh, I tweaked my knee. Like I slipped on the ice and tweaked my knee this weekend. And went on a little BPC and it dramatically starts settling it down. If you tear a tendon, things like that. Also, if you have a surgery, help with repair. Back in the old days, we used to actually inject growth hormone into joints, and it was really helpful. And then they sort of banned growth hormone. We couldn't get it anymore. But growth hormones also had some downsides. It was a little bit tricky in terms of how much to inject without getting side effects from it. So what we came up with is there a way to get the benefits of growth hormone, which are going to improve? That's how we grow, right? That's how we regenerate when we're little. is growth hormone. But we don't have much growth hormone as we get to be older. So what you do is something called AOD 9604. AOD is a peptide that you inject into the joint. It's a fragment of growth hormone. And it can actually stimulate the growth of cartilage in the joint. This is looking at mouse studies, and you can see this is a big old ulcered area where there's no cartilage on the knee joint, and this is using hyaluronic acid with AOD, so this is that visco supplement with AOD, completely repaired that cartilage defect. So you inject it, usually you do one injection a week for like 5 weeks, and then I have patients who just come in periodically, get a little boost of it, and they keep their joints really fine. The AOD by itself did work. You can see it improved it, but not as well as when you mixed it with hyaluronic acid. So mixing it with a very viscous substance seemed to help the cartilage even more. And then, after we basically have gotten this environment, right now, what have I done? I've reduced the inflammatory cytokines. I've increased the anti-inflammatory cytokines. I've helped my mitochondria by killing off the bad ones, right? All those different methods we talked about. I've improved, so increased autophagy, and I basically have everything in order for now you're in a healing state. Now everything is going to be better. Now, can I reverse damage done? Now this is where my platelet fibrin matrix and stem cells and what we call extracellular vesicles, now they maybe will have a chance of helping. They're not going to have a chance of helping if I just throw them into a knee. So platelet fibrin differs from platelet-rich plasma. Platelet-rich plasma is this. It's a liquid. We mix it with fibrin that we extract out of the red cells. It turns it into this. So if I'm trying to repair inside a disc or a cartilage defect, if I have this nice jelly-like substance, it's going to actually stay there. If I inject this in, like a lot of doctors do, it calls in growth factors. That's how platelets work for a few minutes. I'll say 24 hours, and then they're gone. So it doesn't really initiate much healing. But if I put this and I lay it down over the cartilage or I stick it into a disc or over a facet joint, it stays there for about 6 weeks, and the platelets release growth factors to bring in repair. So it acts as a nice scaffolding. So it's a much better procedure. You can use it cosmetically too. They use it as a filler. And then what we call extracellular vesicles, also known as exosomes. So basically what a stem cell does is it releases these little nanoparticles that contain everything you need to make a human being. Growth factors, microRNAs. So basically, the stem cell is not doing the job. It's these vesicles, right? So if you do stem cells, what you're relying on is the vesicles. What if we just take the extracellular vesicles? And what if we get them, instead of from you, who's 60, we get them from an umbilical stem cell source? Umbilical stem cells are amazingly regenerative, but they're illegal here in the US. Extracellular vesicles you can use. They have so basically we use them as an off-label because they have approval for things, so you can use them as an off-label substance, whereas umbilical stem cells you can't. The problem with your own stem cells is that their exosome population is reduced dramatically as we age. So your own stem cells are your age, so they don't work as well. I can do a lot more by using exosomes. So basically they send signals out to the damaged area. They contain huge amounts of growth factors and microRNAs that are contained in there, and they encourage healing, lessen pain, stop scar tissue formation. Now I can regrow your cartilage by placing a scaffolding of platelet fibrin, lay it with the exosomes, and we can regrow cartilage, we can regrow discs. This is a study that came out last year. They said, and looking at stem cell-derived exosomes as an alternative therapeutic agent in orthopedics, basically it said that cell-free regenerative medicine is quickly evolving to become a reality for therapeutic use in patients, and it will occur because of the unique ability of stem cell-derived exosomes. These exosomes contain a variety of compounds such as microRNAs, growth factors, and proteins to combat that disease. And in this article, they basically said these are probably going to be what everybody should start going to. So there's a lot of cool things, but it is going to be a multi-system, work on the cell, fix the body, multi-system approach. And I'm going to add that you need hormones in play, you need nutrients in play, all that stuff. We heal better when we have adequate testosterone levels, when women have estrogen and progesterone, and men too. And so we need all of those in play. We sort of take what I prefer with all my patients. If I could get all my patients just to do our entire wellness program, it'd be best. I know not everybody's going to do that, but that's really the best way to go. So ultimately, why are we not moving forward? And there's a lot of reasons. This is a study that came out that showed that it takes 17 years for something to be proved safe and effective and actually start getting utilized by medicine. 17 years. Life-saving drugs like insulin. How many people died in 17 years? So things like Pentosan. Pentosan will get approval here in the US. It will come here. It's going to be probably another 5 to 10 years. you know? And so we've got to be on top of these things, know what they do, understand the pathways, and then we can actually stop this, you know, get this stuff to you guys earlier. We have tons of pharmacists we work with that are more than willing to make us things. Where I'm like, hey, can you make us this thing? And they're like, oh yeah, we can do that. I mean, you have to just know how to get around this system a little bit. So I'm going to advocate for you guys to, you know, I know it's a lot of biochemistry and it's a lot to understand, but take home the basics. Basics are, this is a cellular dysfunction. It's an inflammatory disease. It can't be treated by surgery. It has to be treated by treating the inflammatory disease. Now, this study came out actually shortly after right before I actually gave this talk at a big conference, or similar talk, and they said they shot tardigrades from a gun to see if interplanetary travel was survivable. And sadly, after being shot out of the gun at speeds ranging from 1240 to 2230 miles per hour, that the tardigrades at the highest two speeds didn't survive. So apparently, we're not invincible. But I think if we all the key is if we all sort of work together to make a change in this medicine. I mean, I've taken a lot of guff in my life to try new approaches and things like that. And, you know, and I think the key is that my goal is never to say, you know, this is what you should do, but to help you guys to understand and learn it and make your own decisions. And like I said, surgery is still a necessity in a lot of cases, but you've got to focus on that we have to change things at a cellular level. As I look around this room, and I know so many of you are in this inflammatory disease state. And I know I've made the mistake of, you know, just saying, well, I just want to throw some steroids in their back. But, you know, I'm getting less and less tolerant of that kind of behavior. So I think that share the word, listen, don't believe anything I said, but at least look at the data, okay? And hopefully teach other people if you buy in.